There's no such thing as a safe tobacco product, but there certainly are safer by a large margin. It's disappointing that we see a lot of the schism in public health today around vaping and almost forgetting about the fact that most of the people that are filling up our hospital are here because of smoking, not because of vaping.
Hi, I'm Brent Stafford, and this is RegWatch by RegulatorWatch.com. As we've reported endlessly over the past years, there appears to be a schism within public health between those who believe safer nicotine products play a valuable role in helping smokers to quit, and with those who believe that compared to vaping, smoking is the lesser of two evils. What could possibly explain the gulf between these two positions? Joining us today to discuss this question and more is renowned tobacco control researcher Dr. Michael Cummings, professor in the Department of Psychiatry and Behavioral Sciences at the Medical University of South Carolina. He formerly led the tobacco control program at Roswell Park Cancer Center, and in 2002, Dr. Cummings helped establish the ITC-Project. Dr. Cummings, thanks for coming on the show.
My pleasure. Glad to be here.
Well, you are a bit of a legend, so I want to do the first top-line question. Is there a battle being waged over safer nicotine products?
There is, and there has been for many decades, I think. And it really, the schism is those that, see the future really focused on preventing new users from coming into the market. And therefore, they're primarily concerned with youth, young kids taking up cigarettes or other forms of nicotine, versus those of us who've sort of been at the forefront of trying to help addicted adult smokers to get off of cigarettes.
So you've got about 30 years or so, I understand, in tobacco control. Why don't you fill our viewers in a bit on your background?
Well, it's actually 40 years. I wish it were just 30. But I've been at this for quite a while. I started at Roswell Park in 1981. And really learned tobacco control from smokers. So I, started up clinics for people who were calling a cancer hospital and asking for help to quit smoking. And there was no help at the time. And somebody suggested that maybe we should start up a stop smoking class. And so that, introduced me to really a research career in trying to figure out why it's so hard for people to get off of cigarettes, what they experience when they try to quit, how to prevent young people from taking up cigarettes. And, that's been my career path over the next 40 years. I ran clinics. I've, done many studies evaluating, from gum to patches to pills to vaccines to help people quit smoking. And now, large systems. I helped establish the New York State Smokers Quit Line when I was at Roswell Park. And when I came here to the Medical University of South Carolina in 2011, got involved with helping our hospital establish a program to help people quit. I mean, people do a lot of research, but unless you translate some of the research into action, it sort of is meaningless. And so my tact is to, basically eliminate cigarette use because it does so much destruction. 1 in 2 long-term users are going to die prematurely as a result of smoking.
Describe some of your work with the U.S. Surgeon General.
Well, I've been involved in various reports. The first one I got involved with in 1988. I was a reviewer for the report, essentially why people smoke. That was the one that was on nicotine addiction. And I guess they must have liked me because after I sent in my review comments the next year, I got asked to write a chapter for the 1989 Surgeon General's report. That one was on the 25th anniversary. My contribution was primarily around doing the history of smoking cessation interventions, which, they're not very good. It's hard to get people off of cigarettes once they get started. And, of course, there was nicotine replacement therapy, but the U.S. federal government did not announce that cigarette or accept that nicotine was a drug until 1984 when they regulated nicotine gum. That's when it came into the market. And the FDA finally exerted its regulatory authority over all tobacco products really in 2016, but started with the Tobacco Control Act in 2009, which gave the FDA authority to regulate cigarettes and smokeless tobacco. And then in 2016, that was extended to other tobacco products.
So the U.S. government, you had said it was 1984 that they recognized that nicotine was addictive?
Yeah, they sort of got it a little bit late. I mean, there was the 1906 law for FDA where they had a list of things that, could be regulated under the U.S. government authority and various drugs. And nicotine was left off the list. And then in 1938, when FDA assumed authority over regulating medical devices, food products, cigarettes and other tobacco products were left off the list. So it's been a long time getting to where we are today with FDA regulatory authority. And of course, all good regulators know you're doing a good job when everyone hates you, which I think is probably the case with the FDA today. They have a lot of challenges. The market has evolved. And I've written some things about the FDA, as many people have, in terms of their regulatory authority. I have a citizen's petition that I filed a few years ago, urging the FDA to follow through on its framework of a nicotine regulated market, but with acknowledging a continuum of risk with some products coming in very dirty delivery systems, in other words, the combusted products, versus the cleaner nicotine delivery, non-combustible products, which include things like vaping, but also oral tobacco products. And who knows what will come next.
Is it fair to say that nicotine has been unfairly demonized?
Yes, I think it is. Because it's been linked to cigarettes, appropriately so. It's the reason that people are persistent daily smokers for not only years, but decades, to the point where they get sick from smoking. And so nicotine is that reason. So it is the fundamental link, but people die from the tar. They don't die from the nicotine. Now, a lot of people are confused about that. And that is one of the challenges that the FDA, I think, has, and other government agencies, is to try to correct misperceptions that the public has about nicotine and, safer nicotine products. There's no such thing as a safe tobacco product, but there certainly are safer tobacco products by large margins. So you can look at, nobody would tell a non-user to use a nicotine patch. They would. You ever use nicotine gum? I've tried nicotine gum. I'm not a tobacco user, but it'll give me a rush and a headache, and it's not very pleasant, to be honest with you. But you wouldn't want non-users using any form of nicotine. But for an addicted smoker to switch from deadly cigarettes or cigars or pipe tobacco to a non-combusted product makes perfect sense. And it's disappointing that we see a lot of the schism in public health today around, vaping and almost forgetting about the fact that most of the people that are filling up our hospital every day are here because of smoking, not because of vaping.
Yeah, I guess that's a really good point. Let's try to make here right off the bat. How much of an impact do smoking-related disease still have on the population in the United States?
It's a huge impact because you have to go back historically to the cohorts of men and women who took up smoking in large numbers, in the 40s, 50s, 60s. And those are the patients that we see showing up in our hospital today. And, that will eventually peter out. We are seeing a sharp decline in lung cancer incidence that's directly resulting from the decline in cigarette consumption that's taken place. But we can accelerate that decline by moving people off of deadly cigarettes sooner than later. And that's the debate. Are we better off just letting the clock time out in the United States and throw all our effort into preventing young people from using any form of nicotine? Or is there a benefit to be had by helping those who are addicted to cigarettes, particularly older people? Those are the ones you're going to get the benefit from in terms of return on investment in preventing lung cancer, COPD, heart disease. I personally think there's got to be a balance, but I can see the other side saying they're hopelessly addicted. Smoking cessation methods haven't worked so well in bending down the curve of smoking rates. And so why do we think vaping or alternative nicotine products will make a difference?
So what does the research show with regard to efficacy of vaping, nicotine vaping products in terms of smoking cessation?
It's mixed. There are certainly randomized trials that are somewhat persuasive, but they're not as generalizable because you self-select people into the randomized trials. But there are a number of those, and they generally consistently show what you would expect. You give people a nicotine replacement product, they smoke less, and therefore you get more smoking cessation, and that would be a good thing. And then when you use the population studies, even the longitudinal ones, you've got a lot of mixture of use. A lot of use of vaping is occasional. It's not converting people to regular daily substitution, which is what you really need to do if you're going to be, you don't tell somebody, using a patch or a gum to use it occasionally. You tell them to use it every day as a replacement for cigarettes. It's supposed to help you deal with nicotine withdrawal, so you're not climbing the wall and returning back to smoking again. And the same is true with, vaping or oral nicotine products. If somebody is a heavy smoker, they need to use the alternative nicotine products on a daily basis. And if they do that, then we seem to see more transition away from cigarettes completely, where you're getting former users, or even in the dual users, you're seeing reductions in cigarette consumption and the move to non-daily smoking, which is a step in the right direction.
Can you answer the question on how safe nicotine vapes are?
They seem to be a lot safer than cigarettes, just because of the chemical nature. I mean, you're generating some 7,000 chemicals, 70 plus carcinogens in every puff of a cigarette. And while there are, if you heat vaping products at a high temperature, you can generate some of the same bad chemicals. There's markedly different chemical mixture in vaping. But we all know that the long-term effects are not known. I mean, vaping has been around for about a decade. We don't even know among long-term vapers how many of them there really are. There are some, but nobody's done a good cohort study to follow them, and that needs to be done. I sort of look at vaping like we could have been looking at smoking back in the early part of the 20th century, when the modern American cigarette really got its roots with R.J. Reynolds introducing, the American blend with Camel in 1913, and all the other cigarette companies followed suit. Cigarette sales take off. And had we had a good epidemiologic study, maybe we wouldn't have had to wait to 1950 to have sort of the convergence of evidence that, really created the first health scares around smoking and disease. And it's going to be more complicated with vaping, because if vaping is used the way it should be, which is for people who are smokers to transition away from the deadly cigarettes, then you're looking at what's the benefit gained in terms of compared to what they would gain if they were to just quit smoking. We know there are huge benefits to quitting smoking. Are those benefits eliminated if you do vaping? I don't think they are. We do have long-term studies of people who switch to nicotine gum There's a study done years ago with people with the beginning stages of COPD, it's emphysema and chronic bronchitis. And they had a group that got nicotine gum for as long as they wanted to use it. And over the long term, there was a huge mortality benefit from those who got the gum. They were more likely to stay off of cigarettes and therefore not have their disease advance as rapidly as the group that was in the control that got the placebos. And it was relatively safe.
And it was relatively safe, right?
Yeah.
And I would imagine too, I mean, obviously this is something that we've covered on the show on numerous occasions. It's just like, how do you actually really know if you've got a former smoker using a vaping product and they develop cancer? Did the vape give it a cancer, or was it the 20 years of smoking?
Well, you have to know the history. And I go into the courtroom all the time to, testify against cigarette companies, and their lawyers are always very good about looking at alternative causes of somebody's disease. So be relevant to look at the history of exposure, be it from cigarettes or vaping or other sources that may cause somebody's disease.
Have you ever had to testify in court either for or against nicotine vaping products?
Well, I only really do cigarette cases. I've been asked to do the cases, and there are a number of trials, ongoing against the vaping industry in the United States, and I've declined participating because I guess they don't want my views, because I think vaping, has a benefit. It's certainly not a benefit for a young person. I don't think it's a terrible harm necessarily, other than addiction. And addiction could lead to ill-gotten gains, certainly in the, if you get addicted to something and have to spend your money to buy, the alternative nicotine, say a Juul product or whatever. I mean, the company should be held liable for having you to, taking away part of your free will, essentially, to, not have to use that product and spend the money. But in terms of health risks, I think it gets a little harder, at least with the data that we have available, to say there's real harm, even in young people who are vaping. And so, but in many of the cigarette cases I do, and when I read the histories, particularly in recent years, it's not unusual to find these smokers who've struggled. They've tried the patches, they've tried the pills, they've tried cold turkey and switching to lower tar cigarettes under the illusion that somehow that was going to help them get off of cigarettes and lower the harm. And many of them find their way to e-cigarettes, and some of them quit. And so that's what I see. And vaping is an interesting, I was never a fan of vaping when it first sort of showed up in the early part of the 20th century. I was a skeptic. Yes, another, so-called reduced harm product out there. And it really was smokers who educated me about, just like they educated me in my clinics, that this is something you should pay attention to. And I think we should.
So colloquially, that's like, I saw the light.
Yes. Well, and we should be, as a scientist, you've got to be open to change your opinion when you see the data. So when you see more and more people who are, struggling to get off cigarettes, who are finding vaping as a way to stay away from cigarettes, I don't think that's something that we should ignore at all. And we should be listening to the smokers. Unfortunately, the way public health has sort of evolved, it's been a war against smokers. And that was never the intent. I always have viewed myself working at a cancer center, originally at Roswell Park, and now here at the Hollings Cancer Center at the Medical University of South Carolina. I'm an advocate for cancer prevention and working with smokers to prevent them. Nobody chooses to get cancer, and we shouldn't be facilitating them getting cancer. And if there's anything that we can do to prevent that, we should be doing it.
So what do you think lies then at the heart of the discord, the differing positions?
Well, I think part of it had to do with clean indoor air laws, which were, appropriate, because what it did was change the social norms around smoking, because it introduced us to the fact that you shouldn't be riding around in a tube full of smokers, like airplane flight attendants were exposed for decades, or having to go, to your favorite restaurant or work in a restaurant and be exposed, or a casino, or all the various places where people were exposed, and there was harm. And so that, created a different denominator, but that's been taken to the extreme, I think. And, smokers now feel ostracized. They don't want to expose their family members. And most smokers I know have rules about smoking. They try to be considerate. They will go outside. I mean, that's why clean indoor air laws worked, because they were largely self-enforcing. You didn't have to have the smoke Gestapo come in to, tell people, not to be lighting up in the bar or the restaurants. People sort of got it once the evidence was there. So science sort of drove that, and that was good. But taking it to the extremes of making smokers feel bad about, being addicted, which we do in a lot of other areas. People have other drug addictions, but those are medical issues, and they should be treated as a public health problem, not as a stigma. And so, I work here in the Department of Psychiatry. We have behavioral health programs to treat people trying to get off of, opioids and cocaine and alcohol. And we utilize all kinds of harm reducing methods for those folks. And they were not always accepted. And some of the methods that were shunned decades ago, like clean needles, teaches lessons. But, again, harm reduction in the other drug area really came also from the drug users themselves, and recognizing that the goal is to prevent, premature death, and letting people have a quality of life that's reasonable for living.
Well, and let me ask you that, because from our view, often it seems that tobacco control doesn't seem to care a lot about smoking deaths anymore.
Well, I think that's wrong. But I do think the schism reflects that. And I think some who are focused on youth with a passion to prevent uptake do ignore, to their peril, I think, the harm that it causes adult smokers. And we shouldn't give up on those adult smokers. And I think there's a lot of lip service given. Oh, yes, we also support, insurance coverage for this or that. Really? Try to get reimbursed for treating smoking in a medical setting. It's sort of a joke. It's not, really treated the way it should be, like it is for treating hypertension, for example, as a medical condition. And that I don't think is going to change anytime soon. I really am very supportive of, FDA, Dr. Gottliebs' approach, where he said, we should go after cigarettes and reduce the appeal of and the addictiveness of cigarettes. And very low nicotine standard makes a lot of sense. I know not everybody on the harm reduction side agrees to this, but I think it makes a lot of sense, because it would reduce the thing that reinforces the persistent daily use of cigarettes. And when we ask smokers about it, they don't want to be addicted. They want choice. And, the best way to give smokers choice is to remove the thing that makes cigarettes so deadly, which is that they are engineered to be addictive, and they don't have to be. And many smokers, if you want to smoke for tar or for, blowing smoke rings or whatever the other cues, and there are other reasons that people do enjoy smoking, fine, go for it. You can do that with a very low nicotine cigarette. But many people, when they're switched to very low nicotine cigarettes, and these are people not intending to quit, they smoke less, and many of them transition to quitting. And that would be a benefit. Now, where do they go? And if you had alternative lower risk nicotine products, many of them might migrate to the lower risk products like vaping or oral tobacco or patches or gum, or heat tobacco products. And that could save some lives.
Dr. Cummings, tell our viewers a little bit about the Tobacco Reform Initiative, the National Tobacco Reform Initiative.
That was the old folks club for smoking cessation. I think they really got started with John Seffrin, a former CEO of the American Cancer Society, and Alan Erickson, and a few other folks who were brought in to really address around the 2014 period what seemed to be little attention being given to stalled smoking cessation rates in this country, where all the emphasis was really being garnered really in terms of preventing youth from taking up vaping for the most part. And so we created this, organization to try to provide increased awareness around the problem of cigarette use in adults, and have communicated with, the FDA. We have filed comments to the FDA on behalf of, sort of senior tobacco control people who'd sort of been through the war. You can see some of them there, Dave Abrams and Alan Erickson. He was former vice president for the American Cancer Society, did many of the famous American Cancer Society anti-smoking campaigns, Great American Smokeout, probably being the best known of those, and John Seffrin. So basically, we were just trying to say, what could we do? What 3 things could be done nationally to sort of accelerate a reduction in adult smoking? And the 3 things that we came up with are sort of obvious. I mean, raise the price of cigarettes, and continue to promote clean indoor air, and make available, existing smoking cessation treatments. So standard tobacco control things. And then the third one was increase the availability of lower risk alternatives, a place for smokers to go. And I think those 3 things still hold today. We haven't really done a very good job with the alternatives. I mean, we're waiting for the FDA to bless, the PMTAs. We have one e-cigarette Views that's been approved. We're waiting to see what other products they'll approve. They have approved IQOS, but IQOS is no longer on the market because the cigarette companies are fighting between themselves over patent rights and so on. But and there's very little incentive for cigarette companies to give up the profits. The profitability of cigarettes are so enormous. I mean, the regulations really need to shift where the profit center is. If you make it harder to make money selling cigarettes, then there'll be opportunities to make money selling lower risk products. And if you can get over worrying about who makes the money and focus on saving lives, we could actually make a difference. So differential taxation of, the lower risk and the higher risk products would make a lot of sense. I think regulations to reduce the appeal of cigarettes. I'm a big fan of a menthol ban on cigarettes and cigars, but not extending the flavor restrictions to the lower risk alternatives. That's where I think differential regulations would make some sense.
Do you think regulators are making science-based decisions then with regard to vaping?
I think they are. The FDA, Mitch Zeller certainly has, and Dr. Gottlieb, when he was the head of the FDA, put forward a reasonable framework, although some of the elements of that framework, I think politics probably interfere with it coming forward in full bloom. And of course, it doesn't help when, we get the fear, mongering around, vaping in youth. I mean, a lot of the vaping efforts, anti-harm reduction efforts that I see being promoted by, groups that I think have a reasonable place to have their voice heard, but they sound very much like the temperance movement of the early 20th century. It's like it's being reinvented, as I say. So, we have, moms against vaping. Well, I can see moms being a pretty powerful vaping force and not being happy about their kids getting addicted to vaping products. But, that's just a vehicle for some of the politicians to be moving to ban vaping products. And, let's not, I personally think, and I've heard stated that, banning flavors in vaping products is just a way of banning vaping products.
Well, it certainly would have that effect, but you don't even need to go that far. Just look at the PMTA process. They're not banning flavors, but they're doing a pretty decent job of wiping out a large majority of the vaping industry.
Right. And the flavor bans have led to synthetic nicotine, which, is just, shows that the nicotine business is very resilient. And, they're going to find a way to avoid being regulated. What we really need are standards for different product categories that make sense. And there are some bad players, frankly, in the vaping business, and they haven't helped themselves as I'm an outsider in the public health area, but I think there are some companies that have tried to do the right thing and move forward. But I have also seen some companies that just, were looking to make a quick buck and move on. And so the whack-a-mole regulations you have, which is what FDA goes through a process. They've eliminated some vaping products from the market, and then they show up on a different website under a different name a few months later. That's not helping anyone. What we need are some clear standards and some truth-telling about the relative health risks of different tobacco product categories. Is it so hard to understand when you burn something and generate, 7,000 chemicals, that's worse than, heating something and generating a whole lot fewer chemicals? I don't think it is.
With regard to nicotine vaping, is the genie out of the bottle and can't get put back in?
Yes. We've got a, multi-billion-dollar industry. It's global. And I think the genie is out of the bottle. You can't stop innovation, and it's not surprising that young people were the first ones to take up vaping. Young people were the first ones to take up cigarettes when, Camel invented, or, Reynolds invented Camel cigarettes with the modern blend, making it inhalable, creating generations of cigarette smokers addicted to the product. And young people were the first to go to filters. So is it surprising that young people, were the first to go to vaping? It's the same as computers, mobile phones, almost anything. And, if you go back to areas of innovation and technology, it's not the old people. The problem is it's the old people that would benefit the most by getting off the cigarettes today. So how do we make that happen? And I think the way to make that happen is devaluing the cigarette, very low nicotine, menthol out, high taxes, and providing truthful information about the alternatives. And making those, you got to make those alternatives easy to use and accessible to older smokers. Right now, the industry is just lowering the price. They're still making money. So as long as they can still print the money with the cigarette machine, which is what's going on, we have a big hill to climb.
I wanted to ask you about the lower nicotine products because one has just been approved by FDA. And I've always thought that at least the old stories that I used to hear about the light cigarettes was that a user would inhale more deeply to get what they needed, and thus they would do much more damage. And so wouldn't a lower nicotine cigarette also present the same issue?
You would think so. And in fact, that's been the utility of the science that's come out, which has shown that if you go below a threshold level of nicotine, the person can't compensate enough to keep people smoking, because with low, light and ultralight cigarettes, there was enough nicotine available in the tobacco rod to be extracted that allowed the person to compensate and keep smoking. And what the cigarette companies recognized early on is you sold more units and you kept people smoking longer who might have otherwise abandoned smoking. So it was a win-win for them. But if you go to a very low level in the rod, so it's really talking about the amount of nicotine available, then compensation is it doesn't really exist. And that's what the scientific studies that FDA has funded over the last 10 years have shown. So that gives me confidence you can go to a very low nicotine level. And the industry had done those studies back in the, certainly I can find them from Philip Morris, done in the late 70s, early 80s. And ironically, they introduced a product that would have met that standard. Next and Merit D-Nic, which was their denicotinized cigarette, introduced in the late 80s. And of course, they didn't acknowledge in the late 80s that cigarettes were addictive or dangerous. So, why should we? But now we know, and they could have. That just shows you they could have been offering those, and they would have saved so many lives. And I personally don't know how the cigarette companies get away with continuing to sell, what is clearly a defectively engineered product, knowingly is going to be responsible for 1 out of 2 long-term, users of their product to die prematurely when you have alternatives. And they could lower the nicotine in the cigarette. They could prevent the compensation. And it's been doable for decades.
Here's, for our audience, a letter coming out of the Iowa Department of Justice, Office of the Attorney General, and that's Thomas J. Miller. And you're part of this letter. I'd like you to address what exactly was it that you guys were trying to achieve with this. And also in here, I found it very interesting that you were using the term smoking harm reduction as opposed to tobacco harm reduction. And I'm wondering if you could address that too as well.
Sure. I mean, the smoking versus tobacco harm reduction is just being clear about what we're talking about, which is you benefit from getting people off of the smoke. So smoking harm reduction versus not all tobacco products generate smoke. So e-cigarettes, heat tobacco products, oral tobacco, or non-combustible forms of tobacco. So it would be safer. So that's the rationale there. The letter was written, early on when President Biden came into office. There's, a lot of misinformation about science. We see it today around, issues of the vaccine and COVID and many issues in science, climate science, and certainly in the tobacco area. And so we wrote to the task force to let them know about some of the misinformation we saw getting communicated to the public, which we thought was counterproductive and something that the White House and their task force on scientific integrity needs to pay some attention to. And we hope with the new commissioner to the FDA recently this week getting approved by a slim margin, but thankfully was approved, given all the issues that are confronting the FDA, that the policies that come forward will be based on science and not on emotion and rhetoric and ideology. I mean, it should be based on the facts and the science. And, the science does evolve. And wherever the science takes you, that's where the policy should take us. But I think a lot of the policies, like the flavor bans for vaping, really are based more on emotion rather than science. We don't have really good evidence that those policies will reduce youth vaping, which is why they are being proposed.
Yeah, and certainly there has been some research out that has shown, one out of Yale University, that the flavor ban might actually even increase some teen smoking.
Yeah, and that was the study out of California looking at the San Francisco ban. And, the San Francisco ban was good, except it went too far. I mean, why didn't you just stop at cigarettes and cigars and combustible tobacco with your flavor ban? But they moved it to take account treating equivalently all tobacco products, which makes no sense. And a number of communities have followed suit, and it's really wrong and non-science driven. And that's what we communicated in our letter. A number of us signed off on that letter, and I was happy that Tom Miller, Attorney General from Iowa, and also the new chair of the state attorney generals, was willing to put on his letterhead. And Tom has been an advocate for science and facts to drive policy rather than ideology.
Is there a difference between science conducted in the United States and, say, science conducted in the UK? Because there appears to be two different understandings. Actually,
it's interesting. The United Kingdom, which has definitely taken more of a science-based approach to looking at and weighing the risks and benefits of alternative nicotine products than we have here in the US. In the US, it's a lot of the science is based on trying to, it's focused on the danger. And so much of the research is focused on non-tobacco users, kids taking up vaping and not looking at the potential benefits on the other side, where there's been, I think, more of a balanced presentation of that evidence in the UK, which I think really harkens back to the UK's history in the area of harm reduction in drugs. Reading a very interesting book called Undoing Drugs. It talked about some of the harm reduction around heroin use and AIDS prevention and so on with clean needles, and actually doctors even prescribing heroin as a way to, get addicts their fix without having them have to, risk exposing themselves to the AIDS virus and so on. So it seems, they're saving lives, which is what doctors are supposed to do. And that grew out of work coming out of Europe, particularly in the UK, Liverpool and so on in the 70s and 80s. And so it's not surprising that they're a little bit more open. I think it's just been baked into the culture of public health and how you deal with drug addiction. It's not without controversy, even in the UK, but in the US, we've always been, just say no. The Nancy Reagan, and we know that prohibition doesn't work. It didn't work for tobacco and cigarettes. I mean, many states in the US banned the sale of cigarettes in the turn of the 20th century. And, that fell away by the late 20s. And it was ineffective, and the same happened with alcohol and so on. And it's interesting, the experiments in prohibition came up during the COVID lockdown in South Africa, where an illicit market of cigarettes grew, and now the government didn't get their tax revenue and have little control over the market. And they've rescinded their restrictions on the sale of cigarettes there. Bhutan, a little country sandwiched between India and China, a little hard to get tobacco products to. I don't think they grow tobacco, so it all sort of gets imported in. They banned cigarette sales a number of years ago, and they have very low smoking rates to start with. So, but quietly this year, well, I guess it was probably in 2021, last year, they removed the prohibition. And they went back, they said the illicit market is more of a problem, and we don't want to be locking up people for smoking. That's not consistent. So there are some examples, and they've failed. And so how do you live with cigarettes, devalue them, and offer better valued, lower risk alternatives for those people who want to choose to use nicotine, but in a safer way?